Hi, everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with leaders in healthcare and technology. Today, we have a guest, Trevor Colhoun. He's CEO and co founder at TPN.health. Welcome, Trevor.
Grateful to be here, John. Thank you.
Yeah, so it's interesting how we met through a friend of a friend, but you've built a really interesting network. Tell us a little bit about yourself and your network, TPN.health.
Yeah, so I mean, just quickly about myself, because that's very unimportant. I'm an entrepreneur and very involved in tech businesses for a long time, and been operating tech businesses, and came about TPN probably 3 years ago through the other co-founders, Christopher O'Shea and Jimmy Mooney, who came across of developing a great business process of treatment centers, bringing them in, verifying them on program, and then bringing that transparency to the marketplace. As we got together, Chris wanted to really elevate that. And I was excited to be involved and elevate it. And really what TPN has built today is a connected business platform for behavioral health clinicians, allowing them to engage with each other, refer to each other, connect, really see marketplaces where they are digitally and nationally. But more importantly, it's how they come into the system. We bring them a lot of tech utility in terms of virtual education so they can maintain their licensure. We give them the ability to track their license as they go, but then also different resources and utility for organizations, being able to see treatment and acute treatment out there to find for themselves. But I think what you're hearing is we don't deal with the customer. This is a business platform. It's really the digital railroad tracks of behavioral health, and taking away what traditionally for years has been an analog space that's, you've got the clinicians in siloed across the country, and nobody really can connect and know what's going on and see who's doing what. And that's really the problem we're solving.
Yeah, I think it's really interesting. And, you probably have a really good insight into this kind of behavioral health professional space. What are you hearing from them in general? And kind of what's the state of mental health? Obviously we've seen some explosions of it, and COVID moved to telehealth, and, but what are you hearing from them? What are their challenges and problems?
Well, I think the first thing, the challenge is they're just overwhelmed. I think they're overwhelmed. We had a digital light switch go off with COVID, which was something that needed to happen. And so those are maybe some positive things that happened from COVID. So bringing this industry up into away from the fax and phone, really where it was 2 years ago. And I'm not joking, to bring it in a space where they want to be able to efficiently see the patients they want to see that fit their practice, find those patients, build a business, be able to learn new modalities, interventions that fit the things that they care about. But I think the overall sense is we're in a crisis in the behavioral health space. And as we look at this crisis, I think it's a little unique. I think we obviously think it's the correct way to look at it, where most people say, hey, you have a behavioral health issue, you need to be connected with a therapist, right? Mm-hmm. We don't really think it's that easy. We think you need to step back a layer and really look at the infrastructure of behavioral health, where other industries, there's infrastructure, right? You even look at the medical side of the industry, where you go to a medical system, you go through a clinical process of recovery, you go through tests, you go through see other doctors, you go through a process of recovery. That doesn't happen nationally or even in small geographical areas for patients. They don't have networks that they connect to. So they find their clinicians because their mom saw somebody or their friend saw somebody, right? So they go see that person. That's not a clinical match, right? And so we're looking at redoing that process and bringing the power to the clinician to allow them to engage and connect with other clinicians, see visibility. So when they get a patient, they can say, hey, you're great. We're diagnosing you this way, or maybe we need to find someone to diagnose you. And then we're going to use Trusted Provider Network, the TPN system, to really find someone that actually matches with you, matches with your insurance, matches maybe geographically where you're located, matches with that diagnosis that we gave you, and a correct modality intervention that will get you to a healthy process. So that's really what we're seeing and how we're approaching this market.
I find this fascinating because there is a shortage of mental health providers. So it actually creates an opportunity where people are okay to refer them to the right person that can help them.
Yeah.
Whereas in a lot of other healthcare or other, businesses, like, we're not referring, we're going to take the business and run with it. But I think mental health people want you to find the right provider, and there's so much demand for their services that they want it at the right place. And where do you see that really kind of, carving out, as you say, trying to find the right one? Is it around things like, addiction versus marital versus family versus past abuse? I mean, is it around those types of things, or how do you do that kind of matchmaking, if you will?
Well, we don't do the matchmaking. Okay. So we haven't bought into the algo process at this point where you can take questions and then someone could diagnose you and correctly match you with the correct practitioners. We're not buying into that at this point. And we're really giving the power and the tool to the existing clinician, allowing them to say, hey, this is what I practice and I know. I mean, behavioral health is becoming more specialized in terms of different areas of ones that you've just discussed in different areas of anxiety disorders or trauma or, chemical dependency issues or eating disorders or sexual trauma, whatever the issue would be. It's really allowing that professional to use their skill set and then have transparency in the market to make the correct decisions for that person. I also want to just correct one thing that we push off against a lot is a lot of people say there's not enough providers out there. We don't know that. We really don't know what the providers, we say that for two reasons. We don't know that. One, we don't have an efficient market to even value and judge that at this point, to have all the data. Because we don't have that system, we don't know where everybody is and what they're actually performing. You talk to the payers, the insurance, you talk to the state governments that actually the bodies that are licensing folks, they don't have they know that the person's licensed and they might have their address, but they don't know what specialty or modality or intervention they're working on, where they're working, how many clients they see. We don't have this aggregate data to actually make intelligent decisions about the marketplace. And that's really what we're looking at. We have contracted with state governments. We've contracted with insurance companies that are looking to solve and get the answers to that. And that's what we help with.
Yeah. Well, I guess we'll have to do a follow-up when you get the data.
Yeah.
That'll be interesting.
Yeah.
So I find it fascinating that you actually use CEs as a kind of a real driving force, this whole continuing education requirement behind your work you do. How does that work for a behavioral health professional? They get CEs if they're part of it, or explain that process.
Yeah, it was really a magical thing that my team came across during COVID, where we built the system in 2019, which is really this robust Bloomberg, LinkedIn, connective system with data and analytics. And then we realized, well, we got a great product. How do we get these users in here? How do we change behaviors? We realized through COVID that we could build, in simple terms, is we really built Netflix of continuing education, where we're bringing in other partners to provide very high level, democratized and geographically democratized continuing education, which is bringing wonderful modality teachings or intervention teachings, or just fitting the quality that they have to hit for their 20 hours or whatever hours they have to get annually. What that's done for us, it also really fits into our mission, and our mission is to improve behavioral health outcomes for the behavioral health industry. And part of doing that is let's elevate, the education and the knowledge base of all of clinicians across the country. So those in LA or those in New York or major cities that might get access to fantastic continuing education, those in Boise, Idaho, or South Dakota, or Des Moines, Iowa, can get that fantastic education too. And so it really fit well with our platform, but it fit well for two reasons. One, to grow the platform, but also it just fit well in terms of the mission as well. So it's quite elegant how this came about. And it's one of those things like the rubber ball. It just, we're like, oh, wow, it bounces. This is great. Sounds good, right?
No, I mean, it's so compelling because everyone wants CEs. They have to, I mean, to maintain their licensure, et cetera. So it's a powerful force. I think you did anger everyone in Boise, though. You know, there's some good people in Boise.
There are great. I was just top of my head. I was there in January. I was doing a therapeutic work on myself, and it's a fantastic city.
No, for sure. But no, to your point though, right? It's the CEs available are not equally distributed, right? So that is a powerful idea. How do you vet the people that you add to the network? I think that I find this process whole fascinating. We've seen it on the medical side, right? How do you know they're really a doctor? How do you do it on the behavioral health side?
Well, these people really are doctors, right? I mean, they're just in the behavioral health side. So they go through the same process, right? You know, if you want to be a clinical person, an LCSW, for example, you have to do, I think it's about 2,000 hours of clinical work with your supervised, your monitor. What does that sound like? Like that's a residency. Okay.
Yeah.
So all of these folks are licensed within their states. Okay. So we verify those licenses against those people and certain other verifications just to make sure that they're a real person, which is a little secret sauce. But every person that comes in that gets access to the network is licensed. Okay. Or they've been qualified by a vetted member that said, I know this person, they might be a sober companion or something like that. But they have vetted for them. And that might be a treatment center that we've vetted to come in. They vetted for those. So we give some vetting extension to some of our partners. I'll also point out though, if you are not a behavioral health practitioner, this might be interesting to all your people. We have, we did 102,000 hours of continuing education last year. A lot of it is on VOD as well, or education on demand, and they can be accessed. That is available to anybody. Okay. And you just don't get access to the network of clinicians, which is really valuable and high level proprietary information to those professionals, but you can educate yourself and you can, be enlightened and open to this stuff. And especially if you're a young practitioner trying to get your license, you can come on TPN and get those CEs to actually get your licensure.
And how much does it cost?
It costs that much.
Yeah. I was like, you left off the free.
I left off the free. Yeah, I should. Yeah. We have an interesting model. So, and we're very transparent about it. We think the most important person in the ecosystem of behavioral health is the clinician. We see them as the river that the water that is in the river that lets it flow. And, the payers for us and our model, we're a for-profit business. We're not a non-for-profit business, even though we're a mission-based business, is organizations that want to be connected with these individuals, whether they're insurance companies, state governments, treatment centers, associations. We deal with most of our customers are associations that have large associations of folks that want to techify their association to have engagement tools and engage with their members. So that's really how our model works. And the wonderful thing is the winner here is the clinician. The winner here is the clinician that doesn't have to spend the hundreds of dollars a year to maintain their licensure, to be able to monitor that and have CE tracker and CE wallet to do that. All of that stuff is free, and it will maintain. People ask us, clinicians ask, like, well, when are you going to start charging us? It's like, that's not our model. That's not what we're trying to do.
Yeah, no, it's powerful. And it makes sense. That's a great way to get people onto the platform.
Yeah.
But then I'm also interested in this referral network you've kind of built. We talked a little bit about it, right? Like getting the client, I guess would be the proper term, to the right, behavioral health professional that's needed for them. So tell us about the problem you're solving there with the network and kind of where are you at in that journey?
Yeah, so let's go to 20,000 feet. Okay, so let's talk about the medical side. You have large geographic networks in the United States, like Kaiser Permanente or NYU Hospital or Baylor, right? These are these networks. The opportunity for us is, because this is such a bifurcated industry and it's so analog, that we have an opportunity to come in and build a national digital network that isn't owned by anybody and is really, has a third party, good broker, which would be us monitoring it. Okay. What that allows to happen is you can finally have a network where I would be a clinician that might see a patient, whether it's a family friend or an unrelated patient, they come to me, they might not fit my practice needs. And I could go on TPN and find someone who's licensed, who might take the insurance that they have and be able to see that visibility, might see that they're actually available. These are things that are painstaking processes right now where you're on the phone, finding out who's available, texting back and forth. You can see that transparency with us. And really that's a lot of data science process. It's what's the data? Do I have the connectivity? What are the analytics of that data? And then making that decision. And so referral is that last thing, making that decision. And we see this in maturation of our network as it grows. And we have the feature set to do it. We just are training the clinicians now that this information is available and you can actually do this. And we have all these cool little tools for them to build endorsement networks where they can endorse people and other people can come on and say, who do you endorse? We found that there are Nexus clinicians out there that someone always calls, but now they can say, hey, these are the people that I endorse. These are the ones that I use, and you can see them too and see if they're available and what their story is, because they're constantly updating their profile. And I've changed jobs. I've added a license, things like that. I've added a credential.
It's fascinating because I actually had this situation happen with my counselor, and I wanted to get some help for one of my kids, and my counselor didn't do kids, right? So everyone has these kind of semi built-in networks that they've done over time, but it's maybe onesie twosie, right? It's built over time. What do you do when you're new? What if my kid goes off to college and needs someone, right? There's all these problems of that. So it's so powerful. Can hospitals and health systems use this as well to do referrals? Because we're seeing this more and more, right? Where they show up to the ED, and of course they can't address their mental health challenges really in one visit to the ED. So they want to refer them somewhere. Are you working with the hospitals and health systems to use your network as well?
So this is a fascinating area where we spend a lot of time thinking and planning. We have a strategy here that I want to discuss, but we're not doing it at this point because we have so much to focus on with clinicians.
Sure.
Of the 3+ million in the United States.
Mm-hmm.
Hospitals, this is the very sad story of what's going on in our medical space, where 75% of the discharges that come out of hospitals are behavioral health related. I go to but I have a heart problem, and you find out it's anxiety, and you're having, stress related things based on things that are happening in your life. Sure. Or whatever the problem is. The issues that hospitals have is they do not have access, because there isn't a network of clinicians that they can send and then also track that they've sent them off. Most of those patients that are discharged are Medicaid. Okay. They're with MCO contracts and stuff like that. The fascinating thing is we have several MCO contracted customers, right? Without naming them. So we're building the huge swath pool of these people that actually can service that population in the space. I think I'm in New Orleans, Louisiana. We're in every state at this point. Louisiana, I think it's up in the 30, and don't quote me correctly, someone's going to make some comment, but I think it's 30% of our population is Medicaid. And so those people need to find the qualified provider to deal with their behavioral health. So as what we've built, and we haven't released, and we're not ready to release this for hospitals, is the ability for them to track all the discharges they do, to follow the Medicaid protocols, and keep them, which they're worried about, is out of trouble and in compliance, which is correct. Be HIPAA compliant and be able to send these folks out and discharge them in the appropriate, proper way, and then track the fact of where they went, and have an audit trail for that. But also what's missing here, which I have not talked about, which the big piece is clinical match care, right? And this is the horrible secret about it. And I don't fault hospitals for doing that, because it's just how the system is. They just want these folks out of their hospital, because they're an expense. They're drained on the system. They don't treat them. They're not part of their process, but they're
not going to get paid for them, maybe.
For them, all this stuff, but they have to do appropriate way of discharging them. This allows them to actually, one, discharge them, which solves their problem, but two, solve society problem of finding the clinical match care for that person. So they're not just saying, oh, you have an issue, there's a therapist, right? It's like, it's like, oh, you have a heart problem, there's a doctor, he can solve it. But the guy's,
It's an orthopod, not a
yeah,
cardiologist.
exactly. It doesn't do anything. So that's really the cool thing that we can start to do, which we'll get to that. We call it, in our company, we call it rabbits. Like, there's just so many rabbits to chase, and so we need to focus on, the most important rabbit and what we want to accomplish, and then build off of that. And for that is the clinician.
Well, I mean, Trevor, you just need to run faster. I think the tortoise and hare says that's not true either. But
yeah. I would love it. Well, you're making me smile. The rest of my team kind of, I like going fast.
No, to your point, though, it is a problem. And so I look forward to seeing how it progresses. And especially, as you said, and we've seen this. I mean, we've covered this so much on Healthcare IT Today, just around social determinants of health and mental health status and access to those mental health resources. To me, is a huge element of that isn't provided by the medical system, per se. So that's why it applies very similarly. So cool. Well, where can people go to learn more about TPN?
They go to TPN.health. And that's it. It's just TPN.health. It's not .com. We're a .health moniker because we're a edgy, forward-thinking company. So we're taking an edgy, forward-thinking handle.
Nice. And they can just sign up. If you're a behavioral health professional, they just put in their info and sign up. If you're a health system that wants to force Trevor to open up this referral network, you can hit the contact page and say, let me know.
Yep, most definitely. And we'll decide if that's where we want to go right now. But we have a lot of got a lot of water to drink at this point. But we'd love to hear and talk. And maybe out of this a partner comes about that we could do a pilot with them. It's a lot of it. It's an exciting time. I do want to make one last comment, which we always find interesting, because most people, when they talk about behavioral health, they talk about stigma, and we don't see it as stigma. We really see behavioral health as an economic kind of calamity for the customer, because the customer in the United States has choices, and they understand the transparency of those choices. But in behavioral health, they don't. Okay. In behavioral health, they don't know who to see that fits and matches their behavioral health issue. They don't know how long they have to see them until they get recovery. And because of that, they don't know how much it costs. And that comes the economic calamity. Is it becomes this black hole for them of, they say, well, I can go get help, but it's hopeless because I have to go see this person, then I see that person, and I get passed around. But there is help and there is hope. If you are clinically matched with the right person, you can get to recovery. You really can. And these people are exceptional, and they're phenomenal, and they know what they're doing. They really do.
Yeah. What a great message. Thanks for sharing, Trevor. And thanks so much for taking time to share about your network and resources you're offering. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com and search for Healthcare IT Today on your favorite podcasting platforms. Thanks, Trevor.
Thanks, guys. Thanks, John. Appreciate you.